Welcome everyone to today's webinar, From the Belly of the Beast, Lessons Learned from COVID-19 Hospital Operations and Moving to a Post-COVID-19 Healthcare World. I am Emma Goodman with Becker's Hospital Review. During today's webinar, you can submit any questions you have by typing them into the Q&A box you see on your screen. We're looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used today to log into the webinar to access the recording. At this time, I'm pleased to introduce the moderator of today's panel, Peter Dorner. Peter is an Executive Vice President and the Chief Development Officer with North American Partners in Anesthesia. Peter, thank you so much for leading today's important discussion. I'll turn the floor over to you.
Thank you, Emma, and thank you to Becker's for collaborating with us on this very important subject. We're excited to share today. I know there's well over 700 of our colleagues that signed in for this, to hear our distinguished panelists and to hear their thoughts, not only from the belly of the beast, which pretty much everyone is still in, but more importantly, lessons learned and what are some best practices in coming out of that. So with that, it's my honor and privilege and pleasure to introduce our three distinguished panelists. And let me introduce them and give you a little bit of their background. We're delighted today to have Mr. Ramon Rodriguez with us. Ramon, if you could give a wave. Ramon is President and CEO of Wyckoff Heights Medical Center, which is a 350-bed teaching hospital located on the border of Brooklyn and Queens in New York. And Ramon and his hospital have been a leader. Ramon himself is a top executive in healthcare, state government, and social services for over the past 30 years. He's a nationally recognized turnaround expert and has set his hospital on a positive course of improved patient care, as well as fiscal stability. He joined the Wyckoff team in December of 2011. As a seasoned managed care executive, Mr. Rodriguez was co-founder and CEO of Socios Meros and Salud, a Medicare Advantage and healthcare company in the Commonwealth of Puerto Rico. He also served as executive director of Sanos Health Plan of New York, senior vice president and general manager of HealthNet, and president of Columbia Green Medical Center, which is a 2-hospital and 1 skilled nursing facility center as well. In Mr. Rodriguez's state government and social services career, he serves as chairman of the New York State Parole Board, chief counsel of the New York State Department of Correctional Services, executive deputy director for the Division of Youth, and executive director of Union Settlement Association. He also was a trustee of the New School for 27 years and a board member of the Primary Care Development Corporation. Ramon holds a Juris Doctor's degree from DePaul University of Law and Bachelor of Arts from the City College of New York. Welcome, Ramon.
Thank you very much.
Also on our distinguished panel is Mr. Richard Murphy. Richard, give the audience a wave. Mr. Murphy serves as President and CEO of Mount Sinai South Nassau Medical Center, which is a 450-plus bed hospital located in Oceanside, New York. Richard is a native of Long Island and has more than 45 years of experience in the healthcare field. He received his BA from Fairfield University in Connecticut and an MBA in healthcare administration from the University of Colorado. Under Mr. Murphy's leadership, South Nassau has won several prestigious awards for quality, including Magnet Recognition for Nursing Excellence, an A rating from Leapfrog for patient safety, and ranks as a top performer by the Joint Commission. Prior to joining Mount Sinai South Nassau, Mr. Murphy served as president and CEO for Richmond University Hospital, which is a 500-bed institution on Staten Island, one of my hometown stomping grounds. His past experience also serves as executive vice president for the Suffolk County region for Catholic Health Services, which includes being CEO for Good Samaritan Hospital in West Islip, New York, as well as having executive responsibility for St. Charles Hospital on Long Island and also St. Catherine's Hospital in Smithtown, Long Island as well. He currently serves as a member of the executive committee and past chair to the Healthcare Association of the State of New York and is a member of the Greater New York Hospital Association Board of Directors. Welcome, Richard, and thank you for your participation on our panel today.
Glad to be here.
And last but not least, privileged to introduce Dr. John DeCapua. Dr. DeCapua serves as CEO of North American Partners in Anesthesia, or NAPA, which is the leading single specialty anesthesia and peri-op management company in the U.S. As CEO of NAPA, Dr. DeCapua leads over 5,000 anesthesia providers, that's anesthesiologists and nurse anesthetists, et cetera, at over 500 institutions in 20 states, serving over 3 million patients on an annual basis. Dr. DeCapua is board certified in anesthesia and pain management, and he began his career by joining the Northwell Health System in 1994. During that time, he served as chairman of anesthesia at North Shore University Hospital in New York, Long Island Jewish Medical Center, and also supported the Cohen's Children's Medical Center. He also served as the senior vice president of the anesthesia service line for the entire Northwell system, which is well over 20 hospitals today. He also was the Peter F. Walker Associate Professor and founding chair of the Department of Anesthesiology at the Zucker School of Medicine at Hofstra University. As the academic chair, he organized the academic mission for the Department of Anesthesiology at the newly created School of Medicine, which led to the development of an anesthesia research division, a new anesthesia residency program, and several anesthesia fellowships. Dr. DeCapua trained in anesthesiology at the Mass General, followed by fellowships in pain management and cardiothoracic anesthesia. He was on the faculty of Harvard Medical School before joining the Northwell Health System, and he is integrally involved in the issues of peri-op management, clinical staffing models, and lectures nationally on how anesthesia departments can provide quality and operational value to their hospitals. Welcome, Dr. DeCapua.
Thank you, Peter, and it's a pleasure to be on with my co-panelists.
Thank you, Dr. DeCapua. All right, let's jump right into it. Our first question for our panelists, and why don't we start with Ramon and then Richard and then Dr. DeCapua, is to, Ramon, please take a minute and describe your hospital and the services to its community in a pre-COVID-19 world, maybe to kind of set the stage in terms of where you were and the services you were doing before we were hit with this pandemic.
Sure, I'd be happy to. I want to start, though, by saying that I'm very humbled by my, as you call them, co-pilots. They have tremendous backgrounds, are just amazing professionals. And also, I'm really wondering how they got their haircut during the time, last 2.5 months. Usually when I ask this question, they say they do their own hair. I haven't done that, and so now I'm wearing my COVID hair. Our hospital, Wyckoff Heights Medical Center, was founded in 131 years ago by a group of German immigrants who also were involved in a part of Bushwick that was one of the richest areas of the greater New York area. At that point, it wasn't New York City yet. It was still kind of Brooklyn, Queens. They were succeeded by various groups of people who came from outside the United States and migrated to this area, Germans, Italians, and today most of Bushwick is a Latino neighborhood of various ethnicities and cultures from Central America, Mexico, Puerto Rico, Dominican Republic. We, in January of 2020, were looking forward to meeting and exceeding the year before, 2019's projected numbers. So we looked at the possibility of having more than 168,000 visits in our ambulatory center, more or maybe a little less, 93,000 emergency department visits, and then finally 1,400 babies would be born, and almost 14,000 inpatients would come through our doors. That's all done. That's all gone. And we'll talk about that in a little bit. But we have a community hospital that is a safety net hospital with more than 50% of the patients who come to us have Medicaid insurance, and about 25% have Medicare or rest. It's a whole bunch of self-pays and people who have commercial insurance. It's a hospital in the finest sense of a community hospital. Our surgical practice is led ably by Dr. Ahmed, who's been with us for a year and a half, has done a great job. I guess I would just conclude by saying that Bushwick is in Brooklyn, and most of our patients come from Brooklyn, but 30% of our patients come from Queens, mostly in the Ridgewood area, Middle Village, and it's a very polyglot group of people from that area, but most of the people we see are Latinos, and we have spent a lot of time making sure that we can communicate with them. 2 miles around us is about 500,000 people. 1.5 miles from us is a public hospital called I forgot the name of it all of a sudden, but they and we share the work of dealing with a mostly Medicaid and Medicare population. Outside of that, there are very few hospitals. So there's 500,000 people who we have to be responsible for, and many people that need other care. They go to not just one other hospital, but probably a dozen different places. So that's my opening comment, and look forward to speaking some more.
Great. Thank you, Ramon. Richard, tell us a little bit about your organization at South Nassau in a pre-COVID way.
All right, happy to. Mount Sinai South Nassau is we call it a full-service general acute care hospital, has teaching programs in surgery, internal medicine, family medicine, podiatry, OBGYN, and it's a very vibrant place. It serves a primary and secondary population of about 800,000 community members. It employs about 3,600 employees, and we operate on a budget of about $600 million, probably 40% of which is based on ambulatory revenue that comes in through the facility from the outside community. We own about 23 community-based practices, primary care primarily, and those were very, very essential during the COVID period. It's a hospital that, as I think mentioned in the opening, 455 licensed beds, but we staff for about 370 beds as part of this, just the normal routine here each day. It's like every hospital. I think we're very engaged in our community. It serves that a very diverse community, ranging from Freeport all the way into Queens. We're about 8 miles off the Queens border, so we do have a relationship with many residents of Queens. And like many hospitals, it's challenged by the finances. We find ways to make $1 out of 98 cents every day. I have a very committed staff here that during the crisis went way, way beyond what anyone could have expected them, and they just did a terrific job. One of the challenges we faced is we had just embarked upon a $400 million building program that will take us forward over the next probably 5 years, and had just torn apart our parking lots and everything else to make way for a new power plant, a new intensive care level building, and some other related space. And we had to put tents up. We had to do all sorts of things as part of the response to COVID that really challenged the physical capabilities of the campus. But it's a terrific hospital. It's been a growing hospital. We're very proud of what we do here, and I couldn't be more proud of my staff and what they accomplished over the last 12 weeks.
That's great. Thank you. Thank you. And Dr. DeCappa, as you lead a physician services organization that provides services in over 200 hospitals nationwide, what did the pre-COVID environment look like for Napa?
Well, first I'll start off by saying that I've held many jobs in my life, and cutting hair was not one of them. But you can learn to do anything on YouTube, and and I use myself as a test pilot, and I've actually got a following now. So it's, but in terms of Napa, first of all, I'll say to you that it's, I've been with the organization since 1994, so I've certainly watched it morph over the decades. And there's nothing static about healthcare, and there's in particular nothing static about our perioperative world. It is ever changing, and Napa has been changing along with it. I would have said years ago that Napa is a provider of anesthesia services, but that is a very historic way to describe us. We're now basically a partner to our hospitals, ASCs, offices, to manage and serve all of their perioperative, procedural, and pain management needs. And it's very dynamic. Even now, I would say on a volume basis, almost 50% of our work now is out of the main operating room in places like interventional radiology, cardiology, the GI suites, and more into minimally invasive, scenarios, which carries its own challenges and own benefits. Peter described some of the statistics of how many providers we have. We've grown over the years. We find that the industry is consolidating, like most professional services are consolidating, and hospitals are consolidating, and payers are consolidating. And so we've been on that journey for quite some time, and there's still a lot more to do. We employ both physicians and CRNAs, who basically work with our partner sites to determine what is going to work best for them. So we have the majority of our workforce works in a care team model with physicians and CRNAs and anesthesia assistants working together, sprinkling a whole bunch of nurse practitioners and RNs and PAs in that mix. But there are some sites where CRNAs practice independently. And there are some sites where the institution, for whatever reason, case mix acuity, institutional preference, we have MD-only practices. And so we're very customizable to the needs of the local society, which the operating room has a lot of local culture. There's no one way to do things throughout this country. We serve institutions of all kinds, all the way from very small rural institutions to very large tertiary metropolitan urban centers with over 1,000 beds each, to specialty hospitals like orthopedic institutions and pediatric hospitals. And they're all very unique and carry their own needs and challenges. We learned a lot by growing, because every one of these relationships teaches us something about best practice. Every place has something to teach, and we are aggressive about learning and trying to take best practices and deploy them throughout our platform. So as we moved out of the New York metro area where we started, we came to realize the concept of care team modeling in other parts of the country, and that has become, obviously, in healthcare now, the use of mid-level providers or ACPs is now routine and growing. And we jumped on that bandwagon a while ago, and that came from exposure to other parts of the country. So we're really passionate about growing, because it not only creates scale, but it creates a sense of learning about how medicine is throughout the country, and we really do like to seek out best practices. And I will say that it's a pleasure working with both Richard and we have a long history with them, and they are assets to their communities. So it's a pleasure to be on with you both.
Thank you.
Thank you, Dr. Pepper. So that was, so thank you, panelists. So that was steady state, and steady state seemed like ages ago, and it really wasn't that long ago, was it? And all of a sudden, in mid-March, Ramon, or early March, the pandemic hit, and obviously it hit very, very hard in the 5 boroughs in Long Island. Still is hitting hard in the 5 boroughs in Long Island. So as that came into your market, Ramon, in Queens and Brooklyn, Bushwick, Brooklyn, et cetera, what immediate actions did you and your teams take to meet, the new requirements as you were thrust into this pandemic? And also, what were some of the lessons learned and best practices that you and your team undertook as you were dealing with the intensity of COVID and what it was providing and basically creating a new normal?
Well, thanks, Peter. I can't, I have to really begin by thanking John and his team. We are very glad and They showed their muscle, they showed their skills during this very difficult time. Napa provides anesthesia coverage for us, and they provided a lot more during this process. It was a terrific partnership. As we moved forward, what we know retrospectively is that in January and February, we were seeing coronavirus, novel COVID-19 already. Many of us, including members of our administration, were getting sick and couldn't get rid of this thing, whatever it was. We found out it wasn't flu, but it was something else. And we weren't kind of picturing that it might already be here. And I think, all recognized that it was here for weeks before we even recognized that COVID was on the front step of Wyckoff and Bushwick and Ridgewood, et cetera. And what happened was you were kind of swimming around at the beach, maybe in the South Shore and close to where Richard is, not in the bay, but in the ocean, and a rip current hit you. And that rip current was the virus. So we started in early March with one patient who came in with pneumonia, who was 82 years old with comorbid conditions. And it turned out that after we checked and tested her, it took about a week and a half. She was, unfortunately, with COVID-19. And it turned out that she was the first person in the state of New York who died of the virus. And then the game was afoot. The price of everything started going up. The necessity to start to look for answers was upon us. We started out very gingerly, emptying the hallways when we moved a patient from one place to the other, had a special elevator for when we were bringing them up mostly to the ICU. And then things happened again and again, quickly and demonstrably. Our residents, our house officers, our attendings, everyone started coming together, including people who were just tremendous. At one point in the crisis in our emergency department, we had 60 people waiting to be admitted. We saw, and these are numbers that are not totally etched in stone, but we had about 6,500 people who were either COVID positive or persons under investigation. And we lost souls of over 340 patients. And those patients were housed in 3 freezer trucks. And today, which is kind of momentous, today the last freezer truck left us, so that we are now back to a point where we're focused our attention in becoming a community hospital with 30 or 40 people who have COVID-19. I think the biggest issue was the fact that we had to communicate and meet every day and make, sort of audibles at the line in football parlance. We had to make changes all the time, and people were here. We had to get folks out of here so they wouldn't be in a position to get the virus. And we started doing things like taking and closing down the entire ambulatory system we have. We have 5 locations. And those 5 locations, we started moving into virtual patient visits, telemedicine. But at the same time, there were some people coming in who needed shots like pediatrics. So the biggest issue was staffing. There was nothing else other than staffing. We started having people who were coming down with the virus or coming down with total anxiety, which required people to really work harder and work more hours than they would normally work. There were some parts of the areas of our technologists as well as our nurses who we needed terribly. And we started getting and redeploying people from ambulatory who used to be in the hospital, and they voluntarily came in. We moved them in. We canceled vacations. We pleaded with them, and they came to battle. Our perioperative staff, since we started, very few surgeries because we were doing only emergent surgeries. We started getting them to go into our ICUs, and then we started building ICUs. At some point, we had about 70 different people on ventilators. And we only have 14 ICU beds and an intermediate system of about 8 beds. So we were making locations all over the place. And at one point, we were averaging a lot less than what you have, Richard. We were averaging, at this time of year, it would start getting, the census would be getting lower in inpatients. We had about 145 on any given day. For about 4 weeks, we had over 250. And all those people were very, very sick. Then Napa came in, helped us with their own machines, their own ventilators when we needed them. The state of New York was very helpful, and they always came in handy and helped us when we didn't have more than 4 or 5 ventilators yet to be used. And I would say that we did a good job with using our space appropriately. We created a whole bunch of negative pressure rooms. We had HEPA filters all over the place. Our PPE, gratefully, we had enough PPE, but we also had a very difficult time distributing it. We tried to conserve, and I think sometimes that conserving of the PPE made it more difficult for our staff to get it. So we learned from those experiences. And the final thing I would say is that we were in a position in which we couldn't plan. We had to react and do it quickly. And I'm very proud to say that our nursing leadership worked all through day and night. Our chief nursing officer was on every floor, and she made things happen. Our chief medical officer protected us and made sure that we were doing what was right. And all of our people, the person who was our operations person, made rooms and patient beds available when we thought we didn't have anything left. And then to close, we had help from the state, and we also had help from Northwell that we have an affiliation with advice and counsel, and we were learning from what they were doing. But we were only 3 miles from Elmhurst Hospital. And Elmhurst Hospital was my hospital when I was growing up, and it was overrun. And they came to us as well as our community, and it was an incredibly difficult time. Our chief of emergency medicine has worked in crises and hurricanes for the last 25 years. He's a teacher in that system. When the federal government comes back and represents the best of our country. And he was the person who really helped us on an operations perspective to focus our attention on day-to-day operations and to get the job done.
Incredible. And folks in the audience, you may recall, Elmhurst Hospital was the poster child, people in body bags and whatnot, if you watched CNN or Fox or any of the news stations. And Ramon, your team literally was, down the street for those that don't know the geography. So incredible, incredible. But Richard, that when COVID hit, it wasn't just confined to the 5 boroughs in New York and Brooklyn and Queens. It was out in your market as well. So what are some of the things and actions that you and your team took and lessons learned that the audience would be interested in hearing?
Sure, Peter. Yeah, very much like Ramon. We went through a very similar experience. It was clear in hindsight that this virus was in the community far earlier than anybody had anticipated or had thought. Our first patient actually wasn't a COVID patient. It was a gentleman who had fallen, had a little light bronchitis, had been treated by his primary care doctor, had fallen, hit his head, and was admitted for the contusion. And there was something going on there with the bronchitis that deteriorated. Right. And our clinicians were saying there's something here that needs to be done. We couldn't get testing done because the CDC had criteria that had to be met. And this was February 26th, so it was very early in the process. Subsequently, the patient was on a med-surg unit, transferred to ICU as he deteriorated, and it became evident that clearly this patient needed to be tested. I think on day 14, the patient was tested, found out after about a 6 or 7 day delay in the testing response or the response to the draw, tested positive. And what we found at that point is we had 125 employees exposed to this individual who immediately needed to be quarantined and sent home for 14 days. So that's how we began our COVID process here. And that quarantine included ICU nurses, respiratory therapists. I think we had 5 or 7 respiratory therapists go out on that very first patient. So we were immediately in a situation where our resources were being depleted as the surge came on. The governor had asked us all, including Ramon, to give the state a surge plan. We had given them a plan that suggested we might be able to surge from our normal census of 370 to possibly as high as 550. Fortunately, like many hospitals, we've seen a lot of inpatient capacity subsumed by other ambulatory areas and office space and things. So we began a plan to recapture some of that space, and we're able to identify about 550 beds that we potentially could put in place, assuming we had the physical bed themselves. We certainly didn't have that equipment on site here. And we embarked upon a next 2 weeks or so of just trying to find every bed we could find, every ventilator we could find. As it turned out, I think the day after that first patient came in, that was on about, the test came back on around March 10th or 14th, I believe. Within about 10 days from there, we went from, I believe it was 9 patients on March 10th to over 200 patients within about 10 days. So that gives you a sense for how quickly this thing came upon us and how quickly we had to respond to the surge. At its height, we had a census of 505 patients here at the hospital. We had 403 COVID patients, a little over 100 of whom were on ventilators at the height of this thing. And we had, along with that, about 130 BiPAPs going on in the unit. So, this was an extraordinary amount of care. As I said to somebody, this was like running a 400-bed ICU, and this is what we were going through every day. The challenges I think we faced, obviously, were isolation capacity. I think we have 23 isolation rooms here at the hospital. So we did a lot of engineering, got our engineering facility staff. We actually brought in chillers on the back of flatbed trucks to pump outside air into every unit on the hospital. So there was no recirculating of air in the facility. We changed all our dampers. We went in and rejiggered all our environmental systems so we could feed outside air into every unit and exhaust outside, to the outside, so that where we couldn't provide definitive isolation, we at least could protect the staff and other patients from the fact that this thing was percolating. We reallocated, as I said, a lot of space. In one weekend, we took our 17-bed infusion unit and we moved it to one of our conference spaces. That unit had occupied a partial med-surg unit, so we were able to free that space up. We also moved the resident sleeping quarters that had occupied a part of that unit. So we immediately freed up about a 34-bed unit capacity. And as I said, we needed every bit of it. There was a point at which we typically have on site here about 50 some odd ventilators, including our neonatal ventilators. I think in the middle of all this, as we looked down the road and we saw what the challenge was going to be, one of my staff came to me and said, "We've located 40 ventilators in Florida." And I said, "Buy them." And fortunately, we were in a position to be able to do that. $700,000 later, we had 40 ventilators coming up from Florida. And we were able to complement those 50 and push up towards 100 ventilators. We also had contributions from local community groups. We had tremendous support from Mount Sinai Health System, which we had just joined about 2 years ago. And, the medical equipment side of this thing was supported by the supply chain people at Mount Sinai, and we would not have survived this had we not had their support. As I said, the environmental systems, the chillers were changed. We bought the vents. We had tents out in the parking lot. And what we found was very effective was to triage clean and dirty COVID from those tents into different areas of our ED so we could keep a separate section of our ED fairly clean for non-COVID and a section where we could isolate and maintain the COVID population. But as you can imagine, as things reached upwards of over 400 COVID patients, it became very difficult to differentiate that. On the units themselves, we did cohort, and we initially, because the testing was so difficult to have any kind of timely response on, it took a long time to define who was COVID, who was rule out COVID, who was awaiting a test on COVID. And we did see that improve over time when Mount Sinai put in place the Roche unit, and that unit came online. We were able to see 12-hour turnaround on our COVID testing, and that was a game changer for the hospital. We also utilized all of our physician staff, including the anesthesiologists from Napa. Our cardiac cath intensivists were working in the ICU. Napa was doing a lot of the intubations, and that was certainly a high-risk area with COVID patients. So we worked very closely with Dr. Singer, our chair of anesthesiology, who just did an outstanding job, really trying to work himself into a totally different process that he was used to, really getting the CRNAs in. The CRNAs were invaluable. When our respiratory staff, I think at the height of this, we lost 20 of our 27 respiratory staff, and having the CRNAs on hand to work with the vents and the BiPAP and do things like that was just incredible help for the hospital. On the staffing front, we did some unusual things. We have a 3-day, 12-hour nursing model here, so we rather than pay people time and a half on overtime, we agreed to, or we thought as an incentive and as a way to avoid agency nursing staff, we would pay the overtime at 2 times the base rate. And any nurse that would do a 4th day or a 5th day, or any respiratory therapist, there was this incentive to work at a much higher premium overtime rate. And that was very successful. The staff really stepped up to the plate, volunteered for additional sign-ons, days and shifts. And, I won't tell you, but we were very efficient in the use of our staff in terms of how they actually, signed on and scheduled their effort. We did use outside staff. We had physicians from around the country. We had nursing staff come in, and it was just an extraordinary effort on everybody's part. The physicians, I think, learned. One physician came to me afterwards and said this was like going to medical school again, because everyone was working outside their comfort zone. Yeah. And they learned things about their peers that perhaps they saw in the hallway every day, but they never realized that this was the life they lived. And it really engendered a tremendous sense of teamwork and pride, I think, among the physicians, the hospitalists, the intensivists. It was really something to see them gel as a team with a diagnosis that was almost a mystery. I mean, they would work on these patients not knowing whether the next step would accomplish anything, frankly. These were very, very challenging times where no one really knew how to treat these patients. And they all worked with each other, and they leveraged each other, and they relied on each other. And it was just a terrific thing. I think that's the nice thing that has come out of this, is that there's a sense of pride and teamwork that they've seen each other work with, and it's brought everybody closer than prior to the COVID. The nursing model had to change. Obviously, we typically staff at a 2-to-1 ICU and probably a 5 to 6 med surge, 5 to 6 to 1 med surge. The ICU ratios, I think we had over 100 ICU beds in operation at one point. We typically are licensed for 24. We had to go to a team nursing model where the high-level ICU nurses became mentors to the lower intensity med surge nurses and helped them in terms of the high technology issues that we had to address, gave them some support with the skill sets that were necessary. And I think that will pay dividends as we go forward. I mean, we have a very highly trained nursing staff at this point. The ratios did go, though, I'll tell you, to probably 6 or 8 to 1 in the ICU, and probably 10 to 12 to 1 with the med surge units. No matter what we did, there was no way to staff this appropriately. And, we did, as Ramon had mentioned, the outside support. We had about 400 deaths at the facility. We had to bring in 3 refrigerated containers for for the morgue. We typically have a capacity of 12 in our morgue. I think we had a high of 68 deceased patients occupying those units, and that was very sad for the staff. That was a ritual every night to make those transports, and that was extraordinarily difficult on everybody. We redeployed all the peri-op staff. The OR shut down. The elective surgery was over. Most of our ambulatory programming that I think I mentioned generates about 40% of our income was either shut down because we had to redeploy the staff or because of social distancing and the fact that our society was closed and people just weren't coming for clinical services. So all of those staff, outpatient, physician office staff, outpatient ambulatory, assigned inside the hospital. And we could not have done this without having those staff available to support the clinical team. Lessons learned, again, team. We use the Microsoft Teams as part of our command center. And I can tell you that was invaluable to have a broad communication throughout the facility where everybody could dial in and understand what the questions were. There was a continuing dialogue with everyone about what were the problems, the obstacles, the opportunities. And it was just an extraordinary tool to be used with our Hicks Level 4 command center to coordinate all this. One thing I'll just mention in the middle of it all, you can't imagine what 100 ventilators and 130 BiPAPs do to your oxygen supply system. Ventilator alarms were going off across the facility because the pressure was falling. We actually had to bring in a backup O2 unit, hook it into our emergency feed, and have that available, fearing that our main system might go down. And actually, there was a hospital in Queens that did sadly see their O2 system go down, and those patients at that hospital had to be transferred. So you will not believe how much O2 you go through. We generally get a feed once every week, once every 10 days. We were getting fills every single day to make sure that we had enough O2 available. Testing availability, I can't speak highly enough about Mount Sinai and the testing. We started getting results at the very outset back in February. If tests would take 10 to 12 days to get back a response. We got that down to 12 days, and I think now with some of the other units, we're down within just minutes or within hours to get these results back. PPE availability, we went through our challenging times, so it turned out we had enough. We did ration to a bit. Once we cohorted all the patients on the units, we had essentially the whole hospital COVID. We could preserve PPE in a way by not distributing it for every patient, but assuming the unit was full COVID, people could maintain the PPE and not discard it. And that helped quite a bit in trying to manage that process. But the command structure process, the Hicks 4 level communication, the end of day briefings that we did every day were just essential to keep everybody on the same page. And it was just, I think the staff just did a terrific job. We're currently, I think this morning I looked at the census, we still have 30 COVID patients in-house. Our census is substantially down. I guess we're going to talk about that in a little bit, about what we do about the perception that the public has about our safety and whether visitors can visit and things like that. But that's the story here. It's been a challenging time, but I couldn't be more proud of my staff for the effort they made and the results that we've accomplished.
Sounds like a phenomenal team effort, Richard, and obviously Ramona, your shop too, right? I mean, just all hands on deck in crisis mode. And like you said, everyone put their licenses and their experience, they left them at the door and just all pitched in, right, with their expertise and knowledge to make it all work.
I think Richard and Peter and John, one thing that we don't like to talk about, but which I think is inevitable in this process, there are a lot of people who will forever be different because of this experience. We lost 5 people who were members of our staff, none of them clinicians, but these 5 people were people well known, carpenters, plumbers, people who work behind desks, etc. And they passed away during this time. A lot of people got sick. A lot of people are having a time getting back to what they were before. And I think that we have to continue to focus our attention on how we help them to be well. We had one security guard that went to the houses of 2 of the people who died, both of them his friends, and he's still working with us. And every day I see him, we can't do it, but I want to give him a hug. So we're in a position where this thing is going to keep on going. And just like Richard talked about, almost 90%, 95% of the things he talked about we did at Wyckoff, smaller, although our percentage of people with COVID-19, I think, was a lot higher on a percentage basis. It's really tough. And what we need to always recognize is we sometimes look at distinctions between different professions with different people within the hospital, but we have to recognize that they're all professionals. They may be somebody in environmental, but without them, we wouldn't have had what you talked about in a very almost religious way, taking people from our smaller morgue out to the trucks. And one night I went with them. We took 12 bodies to one of those trucks, and we had 85 people there at one point in two of the trucks. It was an incredible thing to see, and I'm just so proud of them. But there is sadness here.
Ramon, I couldn't say it better. We ended up with over 400 staff testing positive. We lost 2 members of our support staff. We have a patient care technician who's on a ventilator, trached at this point. Very difficult situation. We had a physician who we lost. So the mental health aspect of this going forward is extraordinary. And I think we've already begun to have a dialogue with our employees and Mount Sinai and others about how do we begin to roll out the support for our employees. Because this was an extraordinary, I made the analogy, this is like someone coming off the battlefield. This was 4 or 5 weeks, 6 weeks probably of just pure hell. It really was, and it's unfortunate, but to characterize it, but that's what it was. It was a very difficult period.
Yeah, I agree.
Yeah.
I agree.
And I know.
So I'm sorry. Go ahead, Joe.
I was going to say, I know later we're going to talk a little bit about, what do we do going forward. I think what you just heard about how stressful this was for all the clinicians involved, and not even clinicians, talked about carpenters and plumbers and administrative support staff. Well, I think we have to recognize that post-COVID, we're probably going to see a number of people who made decisions about retiring earlier than they would have because of this experience. And as we think about how do we recover from this, and we talk about the rebound of the pending surgical volume, the elective case volume, I think we're going to have to take a very quick assessment of how many people are going to be on that ship post-COVID, because we may find that we're shorter than we were before. And I know that in some areas, perioperative nursing in particular, anesthesia, there was shortages pre-COVID. Post-COVID, I think that may be accentuated. But you're right, that's the outcome of the level of stress that this process really put on people. Peter, I think you were going to cue me up for the next.
Yeah, Dr. Cappo, let me ask you this. Now that we're moving in a post-COVID world, right, or we're beginning to, what are some of the actions that you're seeing and that the NAPA organization is taking in now positioning to be in a post-COVID environment? And then we'll go to Richard and then to Ramon.
Sure. Well, I mean, the first thing that, we have to recognize is that we learned from international experience that anesthesia would become critically necessary during the worst of this illness. So we saw an initial lull as hospitals responsibly shut down elective cases, but we knew that only a matter of time that we would have the sickest of the sick hit the ICUs and it would be overrun. And we would have to, do what we could to help in those environments. And so we did everything that we could in order to make that migration and to keep all resources available to the front lines. And so not an easy thing to do when you see an 80% drop in your elective case volume, which is the majority of the economic funds used to pay people. And so we had to do a lot of things in order to manage that cash flow challenge. And we took the approach of, you have to put the money on the front lines that are most needed. And so we did things on the back end, like we may have furloughed administrative teams that weren't needed because of the volume drop, but we never once furloughed clinicians or cut pay in clinicians, which was unique. A lot of other people took that approach, and they have long memories because post-COVID, they're going to say, when I was out taking the risk, you didn't really take care of me as best as you could. And so we found that in our world, we had to be able to fund those resources, and we did. And the way we're able to manage that is by working with partners like we have here who said, hey, we're going to need help in the ICU. And it's wonderful. Crises are challenging on many levels, but crises also brings out a level of human spirit that allows you to break down barriers and get to what's important really quickly. And during this crisis, we were able to work with partners to say, what do you really need? Well, this is what we have. Let's do literally a half-page amendment to just make sure we document what we're doing, and let's just get to work. And it was that approach that allowed us to be able to get our providers to where they were needed most. And they really wanted to go there. And so that was wonderful. And I would say to anyone who's going to be coping with volume, people aren't really thinking about profits during this crisis. They're thinking about just getting the work done and being able to just make ends meet. And I think that's the first experience that I had through this. Second is protect your staff. And there was a clear shortage of PPE throughout the country, also heightened in New York. And just the fact that they knew that we were trying our very best to get whatever was available to the front lines and message that. And we heard a number of times people were using Microsoft Teams and other communications. But I can't under stress how important it is to communicate broadly about what you're doing, because they'll understand if everyone is short. But what they really want to hear is that you're doing your very best for them. And by just saying, hey, we went out to try to find what was available, and we didn't get everything that you needed, but boy, everybody tried. That goes a long way to having people feel good and confident about where they're working. And we did a lot of communicating, and we did a lot of looking for PPE for people. Finding alternative work for people. Not only did a lot of people have the pride of saying, I need to serve my community, but frankly, when this goes on for a long time, there are going to be a stratus of people, some of which don't need to work and some that really do need to work. And you have to actually put people where they want to be. And so for both serving the community, but also keeping people productive, our approach at finding alternative locations during this crisis was really very helpful. And making it as easy as possible was really the key. So post-COVID, what I would say is don't stop any of that. I actually think we're going to be having rebounds. And I think the rebounds may be more scary to people than the initial crisis, because that is going to be a cementing of the fact that, oh, this really isn't gone. And if you have that, that's the time to really double down on communications, and we intend to do that, with weekly town hall meetings and daily huddles, providing PPE again across the board, providing the resource to the front lines, taking the medicine where you need to in order to keep the resources where they're needed most. We never stop recruiting, by the way. That's something that I would urge you all. Anesthesia prior to COVID was about 20% short. Post-COVID, I expect that shortage to be higher because a lot of people did make early retirement decisions. And so if there's a rebound in certain markets, we're going to find fewer people on the front lines no matter what we do. And so we never stop recruiting. And I would say work very hard to keep the recruiting engine for those critically short resources, and definitely work to make those a destination of choice in order to keep people there, because there's going to be a huge I would say, effort to find people to get those operating room cases going. And there just aren't enough people out there. So make your site a destination of choice, which is done best by having teams, surgeons, nurses, administration, anesthesia come together and figure out how we're going to deal with this pent-up volume. And if you put them at the table and everyone's working together, they'll be happy to be there over other places. So I would say, again, communicate. I would say post-COVID, you're going to need to deal with scaled entities because, first of all, this economic hit that the whole country is taking, but also particularly some of the professional specialties that got hit hard by reduced revenue sources, that took a lot of smaller groups and really it hurt them. And they're looking for scaled entities that can figure out how to weather the storm. We ran a very aggressive incident command system We've done a lot of crisis management over our tenure, and we know how to move bodies from one location where there aren't volume needs to other places. And the ability for an entity to work through regional shifting of staff can meet patient needs in a time when there is shortage. And we did that aggressively. So I would say to you, think scaled entities that can do that, because I think the economic hit to a lot of medicine is not done yet. And local groups are being challenged not only by, commercial payer challenges, Medicare making slashes prior to COVID, but salaries in our profession are going up at a time when reimbursement is going down, and you need to be in a scaled entity in order to ride that storm. And when things like COVID hit, it really stresses a lot of people. So I would urge you to think about larger regional platforms to be able to provide services during the worst of times. We found that was not easy for us, but we were able to get through pretty well by meeting patient needs. And if anything, our vacancy rate got better because of the communication and the approach we took to patient, to provider safety. So think protect your people and think scaled post-COVID.
That's great advice, Dr. DeCappa. Thank you. Ramon, as you ramp up and you prepare to ramp up services, what are the kind of things that you and your organization are doing to welcome patients back to your locations?
Well, it's, I think all of us are feeling in our own lives what many of our prospective patients are feeling about going out and coming to our hospital. I want to make it clear that I think all of us are following a rubric that could go something like this: let no crisis go to waste. So this crisis really helped us in a lot of ways. The first thing that we're doing is we're making sure that we'll be ready in not only welcoming patients, an increasing number of patients, and it's already happening to us. Our emergency department numbers are starting to go up. We haven't been given permission in New York City. I don't know whether there are other hospitals in New York City have been given permission to go back to ambulatory elective surgeries, but we have not, and we're looking forward to that. But one of the areas that we learned something from in quick and dirty ways was training and education. And so one of my lives, I worked in state government, and the people who were brought in during a terrible siege or a riot or something like that were officers who were trained to be SWAT teams. And in our case, the perioperative department became something of a SWAT team for us in critical care. The other folks that are out there, we want to make it possible for them to have different kinds of educational opportunities so they can have it for themselves and for us. And I see us being put in a position where if this happens again, I hope that we're all wrong about this, because I agree with John that we're going to get a punch in the nose and or so. So what we're doing now is we're cohorting our COVID-19 patients. I said before we had in the 30s over the last week or so. We're also going to be defining one of our floors as a outstanding COVID-free zone for a surgical floor, and to keep the process to a level in which you will don and doff before you go into the whole program. We're separating out the professionals, the staff that come into the hospital and go out of the hospital with a different entrance from the public. The emergency department entrance that people are walk-ins on, they'll be going into the ED and no place else. And on the other side, we are preparing, as we speak, 10,000 wall door hangers we're going to be giving out 10,000 of our masks to the public, and also with a note to them. We're going to be placing multi-story welcome signs in our building, because we're 12 stories here in the Queens and Brooklyn area. We're the highest point of this area all around us in developing Bushwick. We are also engaged in a dramatic increase in virtual services, so that we've already done thousands and thousands of visits, and we're going to increase that and improve that process. And we've got a pretty bad website, and it should have been updated years ago. We're going to be using lots of internet services to help us with that process. And I find in this kind of work that we're doing now, this morning I had the first of what will be 3 town hall meetings today, and 212 people came to the town hall meeting. I used to have them in the same kind of modality where you'd come to one of our teaching rooms and I'd get 50, 75 people, except when we're thinking about laying off folks, I'd get 250 people showing up. But the process of engaging virtually is really, I think, a real challenge for us and a real opportunity.
Richard, what are some things your organization is doing to woo those patients back and to ramp up coming out of this COVID period?
Well, obviously, changing the perception that somehow the hospital is unsafe, I think that's a key driver here. One of the problems is the visitor policy. We still have a restricted visitor policy by the governor, so that kind of signals the families that it's, is it not safe to get back? So we're trying to challenge that. We have a marketing campaign. We put a few ads in the paper talking about don't put your health on hold, trying to alert people to the fact that, cardiac disease and cancer, they just don't stop because of COVID, and you need to have these things addressed. And we're here ready and willing to have those, respond to those issues. Using a lot of telemedicine for both internal issues and also with our physician practices, using that very, very significantly. What we found was shutting down the ORs, it's a lot easier to shut down ORs than to open them up again. Trying to get the staff decanted back on the unit away from their COVID assignments it's taken time because this was not, the units had to be decanted one by one. Everything had to be sanitized and cleaned. So that's been a challenge. When we look at the pathway back in terms of surgery, it's not just about the ORs, it's about the primary care physician's office. How many patients can they see in a day given social distancing? What do they have to do to actually refer those patients to the surgical offices that have probably been closed or severely curtailed in the last couple of weeks? So the surgeons need to get everything back in line and do the consults and do the PST testing. We don't know whether those pre-surgical testing patients are COVID positive or not, given the community spread that we see, about 30%, 35% in the community. So all of that has to be put in place, and we're working with our staff to do that. When you have a block schedule in your ORs, you can pretty much throw that out the window when you want us to restart your ORs because everybody is in a different place, and you have to figure out how to make it all work. So I think, it's a lot of different things that we have underway. I think the message to the community has to be, we're here, we're ready, we're willing, and we're able to support your healthcare needs. And we just have to keep hammering that away. I hope John's wrong about the next surge, because I cannot imagine anything worse than what we just came through. But if it comes, we'll be ready and we'll handle it as we need to. But, it's that kind of thing. We're preparing to try to get back to normal, knowing that perhaps we can't or won't, and we'll have to handle this down the road a bit. But I think that's kind of the material that we're working on.
I agree. I think all of us on the line here hope and pray that this doesn't come back, right? But we're all being ready and preparing in the event it does. And certainly you all are a great example of not only digging through this, but coming out of it and coming out of it stronger than you all went in. I know we have just a few minutes left, and the audience attendees have submitted some questions. And if you'll allow me, I'm just going to quickly read a couple of questions. I'll just throw it out to the panel, and please just jump in and give the audience a response. So we'll run through these quickly. I know we have colleagues from Beaumont Health out in Michigan are asking two questions. What kind of visitor restrictions did you all implement? And then secondly, did you all try using anesthesia gas machines as ventilators? So I'll throw that up to the panel.
Let me start.
Of course.
Let me start with the visitor, only because I think Ramon and I have the same protocol that the governor had put in place, which was no visitors except for OB. We had actually, in the beginning, we found that about 25 to 30% of our asymptomatic obstetric patients actually were COVID positive, which was kind of shocking to us when we found that out. And our chair of OB initially said we have to shut down all visitation to the OB unit as well. And we did get a lot of blowback on that from the community, from women wanting their better half with them, and perhaps their mother or father, whatever. But so we did end up limiting to one visitor up on the OB. But otherwise, people have been prevented from coming to the hospital, and that has been a challenge because it's very difficult. And you've heard the stories of the staff holding people's hands. We used telemedicine to have people who were in their death throes talking to their family and trying to communicate the last moments of their life to the family outside the building. We had that happening all the time, and so that was that one aspect. On the anesthesia, yes, we did try to convert anesthesia units. We were successful. We found them very, very complicated, much more so than the normal ventilators. And I think as we were able to deploy more and more of the normal ventilator type units, we relied less and less on the anesthesia units. And that was probably, from a patient safety standpoint, a very good thing, because you really need highly qualified personnel, the CRNAs or anesthesiologists, to really maintain those machines. And so while we utilize them, we put them into the second order once we had sufficient supply to supply the basic ventilators.
Just 30 seconds of, we use the ventilators in the interim when we were about to get whole dozens of regular ventilators. And we had Napa with us, the CRNAs and the physicians to help us out. But those things are so damn heavy and so hard to move around. And they're like something from Doctor Who, those big giant robots that run around. The other part with respect to visiting, and this is the biggest tragic thing, and that is that people on ventilators are intubated and they're paralyzed. So they really can't respond. Maybe they hear something or they don't. So we used iPads, we used other kinds of telemedicine kinds of opportunities. And I'm sure Richard has stories, as I do, of how sad. We had husband and wives in the same room. They were both dying of COVID-19. We had a son and a father. And we had whole groups of family members who were devastated by this, and they'll never be the same. So it's a new thing. I think it's been around for a long time. One of the processes that they talk about with telemedicine used to be that people weren't all that interested. Now it went from 7% of people interested in telemedicine to over 75%. So that's an area we're going to concentrate on, not to stop from having face-to-face visits, social distancing and the like, but that's something we need to really look at.
Yeah, I'm going to make a couple comments on the use of anesthesia ventilators. There are really two big topics there. One is, these are obviously devices meant to be used in the operating room. They were not meant to work in an ICU environment. And the things that enable them to do really great things in the OR create risk in other environments. So, for example, we have valves on anesthesia machines that we purposely make very easy to flip, because we're changing what we're doing to patients very rapidly. But if you just bump up against that valve and flip it, and you're unfamiliar with the device, you create a crisis, with people that are unfamiliar with the equipment. So I would say, if you end up having to use anesthesia machines for ventilators in critical care environments, you need to have your anesthesia department as part of that monitoring.
Absolutely.
You cannot simply teach people in a short amount of time how to use those devices safely, and you need the members of the anesthesia department to be there to help maintain those things. Second, you have to decide very early on how many operating rooms or procedure rooms you need to run during COVID. Because if you take, for example, all the anesthesia machines and put them to use in the ICU, you cannot bring those back to the operating room. They need a really long time of quarantine before you can bring them back to the operating room, because they're metal pipes, there's all kinds of intricacies, and to clean those requires a lot of time. So what you don't want to do is sacrifice all your machines and then all of a sudden have a ruptured aorta patient, some really, a very viable, if you could just take them to the operating room scenario, but you don't have the equipment to actually anesthetize them, and you end up now short on a patient that you otherwise could help dramatically. And so you have to decide early on how many machines can you part with. So it takes some planning of how many rooms can we go down to. Ideally, you don't want to go down any number of rooms because you never know what emergencies can come in through the door. But if you find yourself having to use them, I would say use some but not all, because when you need the most, you can't get them back.
Peter, there's a one aspect that we learned during this whole thing about ventilators. Didn't know it at the start, but everyone was becoming very creative during the whole process. But BiPAP units we found could be converted to ventilators with the right coupler, and that's something. There's a lot of discussion about whether you could put two patients on one ventilator and what to do if you come short. And what we found was that we could have a 3D printer produce these couplers, and then we could utilize the BiPAP as an actual ventilator. So that was a huge help once we understood that.
It was ingenious. Yes. Okay, great. All right, we have time for one last question. This comes from our colleagues at Emory Healthcare in Atlanta, and they're asking, has a new standard of care been proven safe regarding the use of PPE? Because prior, minimal use and reuse was not acceptable. And what have we learned about the safety of our new best practices?
I think that one of the issues that was unsaid in that question is, how safe does your staff feel? It's as important as being safe. How do they feel? Do they believe that you're being supportive of them? And sometimes they don't, because you're rushing to try to be responsive to them. I think we had a big issue in New York State, but we also had a big government helping us out in ways that I think were superior. And in our case in New York City, I think the mayor was really focused on helping us, so-called unaffiliated hospitals, and that are safety net hospitals. And that compounded with all the help we got from Governor Cuomo and everybody else, and Northwell as well, really made for something very special. I believe that one of the real challenges at the beginning, and we had a lot of staff who became victims of the virus, was that we were getting mixed signals from WHO, from CDC, from other locations. And that was creating some real problems. We're now, as advice and recommendations from the state, we're now putting in a big closet a lot of PPE to get ready just in case. And we're now focused on what needs to be done. Just yesterday, the WHO released a new analysis and a new study which talks about simple surgical masks really not doing anything, and that N95 masks need to be used all throughout the locations that we are trying to serve. I think, and I want to put this in as succinct a way as possible, I think what we're looking at is a national health process that really needs to focus on the fact that it is part of our national security. It was and it will always be a situation in which all of us have to come together, because this is dangerous stuff. It came out of nowhere. You may have seen it coming from someplace, but it came out of Italy when it started in China. We're such a puzzle of different pieces that make the United States of America and the world, that right now this is a national security issue, and they got to really look at what we do and to promise us that the government is not going to shortchange us or just forget over time. We had Ebola. Ebola came through. We did some very good work, but this one, in many respects, could have been better. And we've learned things, and we're going to be ready the next time. But we need that support.
Peter, just to echo what Ramon just said, I made that comment to someone just the other day that the financial crisis from 0809 was a they call it a financial crisis. They stressed everybody after the fact, seeing whether or not they had the capital reserve, the requirement to survive another financial crisis. Well, we just went through a health crisis. And if you were to do a stress test on hospital providers and the healthcare hospitals in general, you're going to find that we don't have the reserves. We don't have the capital available. This has been a lesson. It should be a lesson to everyone that there has to be an investment made in the healthcare provider network. And there's some infrastructure bills before Congress. We hope the hospitals are included in those things. But there has been a complete lack of capital investment and frankly, resource investment in the healthcare delivery model. And we found that out with COVID, as Ramon says. It came upon us very suddenly, and we need someone now to do a stress test of the healthcare industry and say, what do we need to do to support it going forward?
You know, only just generally we say one thing. Only when the tides go out do you see that everyone is naked. So that this is a process by which we realized that we've got very little, and use your story, very little oxygen left. We're really needing that kind of support. Sorry, John.
No problem. So, regarding PPE, first let me tell the person who asked the question that in our experience, we believe that proper use of standard PPE ultimately proves very protective. Okay, and that's so to give you the comfort that in our experience, our staff didn't end up using very fancy, expensive, hard to get equipment. They use standard equipment, but the equipment is useless without a protocol. And so what we learned is probably even more important is how you do how people
Yeah.
Today